Welcome everyone to our Breast Cancer Awareness Month webinar. I will give an introduction of myself, but I'm Ashley Nevins, just so you know who's speaking right away. And I'm very excited to have this conversation with a wonderful alumni, Anna Astrich, Vicky Baudet, Andrea Bodine, MC clinician Megan Blasey, as we discuss breast cancer and how you can increase your knowledge. This is a really exciting topic. Hopefully everyone will find it beneficial. We've got a lot of information to share, but feel free to add any questions you have in the chat as we go along. As I said, I'm Ashley Nevins. I graduated from the University of Rochester Simon School of Business in 2016 after taking some time off and working and getting my undergraduate degree. I live in California, Northern California, and I'm the founder of the Bay Area Women's Group and the co-chair of the University of Rochester Women's Network, the regional group. So I also have a lot of Rochester in my family and in my blood. My husband is a University of Rochester alum. My mother-in-law is a University of Rochester alum, and she also is a very active participant in the UR New York City Women's Group, so the New York Metro Women. And so hopefully we've got people from across the country here today. Thank you for joining us. Let's get started with some introductions. But before we do that, I wanted to also just share a little bit about how this came to be, this program came to be. I think it's really important to know just why we're doing these things, why we're having these conversations. First of all, back in April of this year, which seems like a million years ago now, but it wasn't somehow, the Bay Area Women had a live health and wellness event where we had some amazing health experts in the Bay Area speak to us about various topics, whether it was meditation, breast cancer risk, changes related to having children, many different topics for women. And it was such a successful program that we received the request to have an extended version of that. So last month we had an amazing speaker come and talk to us about some of the biases in our healthcare system and some of the biases we have towards ourselves in health. This month, obviously, we're expanding to do a breast cancer awareness program. And next month, we will be doing a virtual meditation. So stay tuned for that as well. Just a little plug. And Sarah did put some information about the University of Rochester Women's Network in the chat as well. And as I said, if you have any questions or anything that you want to bring up as a topic, feel free to mention it in the chat. There'll be a Q&A in the second half of this discussion, and we'll try our best to get to all questions that everyone has. And of course, today's program will be recorded so that we can send this out to you for reference in the future. So now let's get to the actual introductions of these fantastic women who have joined us today to help us learn more about breast cancer and our risk factors and everything related to that. So first of all, we have Anna Astrich. She is a Bay Area woman. I'm proud to say that she was one of the wonderful speakers at our event in April. She's been a speaker for us talking about COVID. And so we're just so thankful to have her in our network. Anna graduated from the University of Rochester with a BS in biochemistry and a minor in Spanish in 1994. She's a public health professional with over 20 years of experience working on preventative health programs on 3 continents, which is just incredible. Anna spent 10 years living in Finland. During her time there, she was diagnosed with breast cancer. I'm sure she'll share a little bit more about that. She used her research and public health skills to try and find out why. Anna promotes better healthcare access and quality for women and children as a program manager for the County of Santa Clara Public Health Department in the Maternal, Child, and Adolescent Health Branch. Thank you, Anna, for joining us. It's so good to see you again. Next up, we have Vicky Baudet. I told her I would try and pronounce it in French, but my French is, I'm still working on it. She graduated from the University of Rochester with a Bachelor of Arts in 2012, having studied public health, African and African American studies with a women's studies minor. She then went on to Boston University School of Public Health. Actually, that was my undergraduate location, so very cool, where she earned a master's in public health, focusing on social and behavioral sciences. I wish we earned a master's in public health, but that's a different story. Currently, Vicky works as a senior project manager at Memorial Sloan Kettering Cancer Center, where she has been for nearly 7 years. In this position, Vicky works with translational research administration, works within the translational research administration, and we, of course, appreciate you joining us today, Vicky. Thank you so much. Next up, we have Andrea Bodine. She graduated with her MD from the University of Rochester School of Medicine and Dentistry in 1988 and completed her residency in 1992. Andrea was an OBGYN, was with the OBGYN site clerkship director at, well, let me try that again. Andrea was the OBGYN site clerk director. I don't want to mess that up because it's important. At Berkshire Medical Center, Pittsfield, MA, for both University of New England College of Osteopathic Medicine and the University of Massachusetts Medical School students for 10 years. Thank you so much, Andrea, for joining us as well. And lastly, we have Megan Underhill Blasey, who is an assistant professor at the University of Rochester School of Nursing, a member of Cancer Control and Prevention at the Wilmot Cancer Institute, and a nurse practitioner at the Wilmot Cancer Institute. In addition to clinical practice, research, and mentorship, Megan has served in multiple capacities as an oncology nursing science leader, both locally and nationally within the Nursing Society and the American Academy of Nursing. Wow, thanks as well, Megan, for joining us today. I really appreciate it. And I think Sarah's going to post the bios in the chat as well, so you can check up on those, because I know I did them quickly and I can't possibly do these women justice with all that they've accomplished. So check out their bios there as well. So let's get started here. Let's jump right in, because we have just such a short hour and I know it'll go by fast. So my first question for the group here is, understanding your health and your health risks, we know can be intimidating, it can be overwhelming. What should we keep in mind when we're informing our healthcare provider? What information may they want to know about us to help assess and provide better care to us? Maybe Megan or Andrea, if you want to get started.
So I can go ahead and start if you don't mind. And if I'm too lengthy, just cut me off, because being an OBGYN, we talk to our patients and it becomes difficult. Get behind schedules, the whole bit. So just as a little background, which probably everybody here knows, breast cancer is the most commonly diagnosed cancer in women in the United States, and the second leading cause of death, cancer death in American women. It accounts for 30% of all new cancer cases in women annually in the United States, and one in 6 of these are in women in the age group of the 40s. The good news is that breast cancer mortality rates have decreased, and in 1975 they were 75, or they've increased. I'm sorry, they were 75%. Now they're 90% survival rates. So we've really improved breast cancer detection and treatment. The main risk for developing breast cancer are, one, being genetically a woman. We'll find out about trans people probably in another 20 years, and advancing age. So most women that develop breast cancer have no other risk factors. So things to think about, have ready for your provider or ask your provider. Have you ever been diagnosed with breast cancer, atypical ductal hyperplasia, or lobular carcinoma in situ? Do you have concerns about changes in your breast appearance or how they feel? And what concerns do you have about your family history? Is there multiple family members with breast cancer? If there's a member with breast cancer, know their age, ask them at diagnosis, ask them if they had genetic testing, what the results were, and if possible, bring those results into the office. That's really important. Do you have multiple family members with either ovarian, prostate, or pancreatic cancer? Are you, I always say this wrong, so please forgive me, everybody, Ashkenazi Jewish ethnicity? And were you exposed to radiation therapy between the ages of 10 and 30? Have you ever had Hodgkin's lymphoma? Next part is, what's your menstrual and reproductive history? Know your age of your first period and the age of your last when you reached menopause. How many years were there between your first period and when your first childbirth? Did you breastfeed your babies? I think everybody knows whether or not they did. Did you ever take hormone replacement therapy? Studies have shown that the combination estrogen and progesterone may increase your risk of breast cancer. However, estrogen alone in those studies did not increase the risk of breast cancer. And estrogen alone is given for women who no longer have a uterus. Things about social risk and things you should think about. Did you ever smoke? And how many years did you smoke? Even if you're not smoking anymore, your risk for breast cancer is increased along with the risk of lung and bladder cancers. How many drinks of alcohol do you have daily? And try to be honest about it. Typically, as a provider, we think it's probably double what a patient tells us, and it should be limited to one or less a day. Maintaining a healthy body weight and exercising. So think about how much you actually exercise. Is it moderate or is it intense exercise? And be able to give that answer to your provider. Some other questions are, what are the screening methods that are recommended? Unfortunately, there's no consensus among medical organizations concerning breast cancer screening and mammography. The benefit of mammogram screening is to decrease breast cancer mortality in the average risk woman. The risk of too much screening are callbacks, anxiety, false positive results with overdiagnosis and overtreatment. A false positive result may result is something that shows need for further testing, and it's not a cancer. A false negative result is something that's missed that was suspicious for cancer. We always think as OBGYNs that we should have shared decision-making with our patients, which means good provider-patient communication regarding their health history, benefits and harms of screening, and the particular woman's priorities, values, and preferences. So, do we need clinical breast exams, and how often should they be performed? You may want to ask your provider. And ACOG says every 1 to 3 years between the ages of 25 and 39, annually after age 40. What is breast self-awareness? And why would this be important? You should know what's normal in your breast, and if there's changes, contact your provider. Almost 50% of all breast cancers over the age of 50 And 70% of those under 50 are actually found by the patient, not through other screening techniques. You may want to know what the average risk for breast cancer is, and how do you know if you are an average risk? Having certain factors, such as personal or family history of breast cancer, ovarian cancer, genetic mutations such as BRCA1 or 2, and young age of chest radiation, prior biopsies with ADH or LCIS, makes you a high-risk woman. If you lack these factors, then you're average risk. So your provider, you may want to ask your provider, how can you tell what if I'm average risk? And there's validated tools your provider may use right there in the office if you have all the information ready for them when you go in. You might want to ask when you should start screening mammograms and how often you should have them. ACOG recommends annually at age 40 and then every 1 to 2 years between the ages 50 and 75 based on your risks. And stop mammograms at 75 based on shared decision making. And again, this is with shared decision making. What are the benefits and harms of having mammograms before age 50? And what about after age 50? Breast cancer is less common, less at ages under 40 years old, and not recommended for the average risk woman under 40. Older women, there's better survival rates and decreased harms of multiple biopsies. And what are the benefits and harms of having them every 2 years instead of annually after 50? The mammogram false positive rate is 61% for annual screening, 42% for biannual screening. So obviously, if during that time there's less biopsies done that are false negative or false positives.
Andrea, I'm going to interrupt you just for a second because I think you're answering a lot of our current and future questions. So I think we'll have an opportunity to have a lot more discussion about that. I'd like to just add that the only, additional information I would add, because the question was, what does your provider need to know? And I think that you've covered all of it, and maybe what questions you might ask your provider. I want to go back a little bit to the family history, because I think that sometimes family, talking about cancer within a family and sharing and communicating about family health history within a family is complicated. All families have different relationships and experiences and connections. And so we don't always have all of that information readily at our fingertips. But it's a really powerful way to support the individual and family into understanding their own health needs and risks. So opening up dialogue about family risk, talking about it, collecting that data, writing it down, right? And keeping it so that future generations have it as well can be really powerful. Because one of the, I work as a nurse practitioner in hereditary cancer care. So I do genetic testing and work with people that have high risk for cancer or are getting tested for their own cancer care. And oftentimes it's very hard for people to be able to look back and know what their family history was because it just never was communicated to them. And so really making sure those lines of dialogue are open, I think is a really important thing so that you can bring that to your medical appointments and be prepared. I also just think that another just important thing about that to remember is it doesn't matter if the family member was born a male or a female. Genetics is a thing that is inherited regardless of sex. And so it's not important just to know your mom's side of the family or just your dad's side of the family, but really understanding your total family history and all the different cancers that have occurred so that patterns can be uncovered and identifying if a person's eligible for genetic testing can really be made clear. So I think really just keeping that in mind as you prepare is an important thing.
Thanks, Megan. And I assume as well, because it can be overwhelming to feel like, oh, I don't, I've got to get all this information and I don't necessarily have it all. I assume, we want to not let perfect be the enemy of good. Share
I
what
think
we
that's
have.
a really important point, Ashley. So cancer genetics has changed rapidly over the past decade. And now it is really just routine clinical practice in cancer care. And so oftentimes people, if they don't know their family history, just by the nature of the pathology of the cancers that are being recognized, they're eligible for genetic testing. And so you may have questions, you may have information you want to bring to your provider, and you may not be able to access that information. Grandma who, or great grandma who had woman's cancer, and died in the 20s, it's going to be very hard for you to ever know what that really was. And that's okay. You don't have to do that work. The more you know, the more you can be empowered to get access to different screening and prevention. But really, this is an accessible, routine part of cancer care. So if you don't have that information, it's okay. You still should feel comfortable bringing it up to your provider and talking about it.
Appreciate that. Moving forward just a little bit on the genetic testing piece, what can genetic testing tell us about our individual cancer risk? I know it can be very intimidating, but what specifically can we learn if we go ahead and do that?
Yes. So genetic testing is offered to people who have cancer and also, or have had cancer in the past, and also offered to individuals who have a strong family history of cancer. And so based on those patterns in the family, genetic testing can be offered. And genetic testing is just one piece of a very big pie. So cancer is a disease, especially breast cancer is a disease that is caused by many different things. And even in families where we see lots of breast cancer, families share more than just genetics. They share patterns and habits and occupations and exposures. So genetics is one piece of a risk pie that can give us information. And only about a little less than 20% of the time do we actually find a genetic finding. And that varies based on the type of cancer. But if we do find a genetic variation, it's powerful information to find. So for the individual who has cancer, it can help their oncology team really understand everything that they need to know about their cancer. If there's particular treatments that might work better for them based on their genetic findings, and also about any future cancer risks. And because genetics is really a family affair, we learn about risk for others and biological family members as well. So if a person is found to carry a genetic variation associated with cancer, their blood-related relatives will be eligible to find out their own cancer risk or lack of risk if they don't carry that same genetic variant, and then really potentially change the family cancer narrative to really focus on cancer prevention and screening, and really catch cancer early or even prevent it entirely. So there's important individual but also family-based information that comes from genetics.
Yeah, and to continue off of what Megan shared, incorporating genetic testing in cancer, in your cancer treatment, or just trying to understand your risk for cancer, it also informs us as clinicians, researchers, and how best to treat the patient. There's this concept of targeted therapies, precision medicine. Here at Memorial Sloan Kettering, we actually have a genetic profile testing concept called integrated mutation profiling and actionable cancer targets, and in short, the acronym is MSK Impact. And through that panel, it's a targeted tumor sequencing test that's available to all of our patients, and it can detect mutations or any critical changes within the genes of both rare and common cancers. So once we, as doctors, as clinicians, whomever, we get those results, it then will help us inform how we can tailor treatment to our patients, right? So as Megan was saying, it's a huge team effort in regards to treating cancer, but genetics can really inform how patient A, if they have these form of mutations versus patient B, we can tailor treatment according to their needs.
Yeah, absolutely. Really interesting. I'm curious to switch gears a little bit from genetic testing to talk a little bit more about the population overall. I mean, I think there's been a lot of discussion lately, thank goodness, that there an acknowledgement that there are disparities in the experience of women of color in the healthcare system. I'm curious to understand from this group how these impact different populations of women in reference to breast cancer. How do these disparities really come into play?
Right. Thanks so much, Ashley, for that question. And it's really important that we look at that disparity. So within breast cancer, when we look at folks within BIPOC communities, so Black, Indigenous, and people of color, what we'll find statistically is that Black women, though they may have a slightly lower risk of developing breast cancer than white women, however, for women under 40, their rate of new cases is actually higher when we compare to non-BIPOC communities. And similar statistics are within Hispanic and Latina women. So though the cases may not be the same as white women, the mortality rate can be a bit higher. So for us, what's important to note is, what are your risk factors? What can you be more predisposed to because you are from a community of color? So we notice in Black women, they have a higher rate of developing diabetes and other health factors that can impact your risk for breast cancer. And so with that information too, we also notice with Black women, they tend to be disproportionately more impacted with triple negative breast cancer. So with this information, it's key for our clinicians and our providers to be aware of that when treating communities from these communities of color. So we have to be very informed and culturally sensitive in how we provide care, and also be informed in what factors can impede why certain communities are not maybe adhering to any treatment in regards to breast cancer. There's an aspect of social equity as well, and health equity and access to care. Another factor to think about when we're looking at these disparities in communities of color is also social factors, age, socioeconomic status, and in regards to their communities, what infrastructures are in place for adequate care? Do they have access to breast cancer screening at a more comparable rate as other communities? So when we look at these disparities, it's not to say that, oh, because you're from a specific community, your prognosis will be more grim. Not at all. It's just us as providers and us as patients, if we're aware of these risk factors, we can tailor how we ask certain questions to our providers, to our OBGYN, and also knowing what limitations the patient may have as in regards to access. Clinicians can then be more culturally competent in providing care to these types of communities.
That's really great. Thank you so much for sharing that. I think regardless of the population, one thing we, all share, I'm sure, is that there seems to be information coming out all the time regarding breast cancer. Do we get screened at this time? Do we get screened at this time? Do self-exams work? Do they not work? I'm not necessarily seeking that information out on my day-to-day, regular day-to-day life, but it comes up. You hear these things in conversations with other women. So I'm curious to understand from this group, how can we stay informed on the latest information, and how do we determine, what information is the most important? How do we kind of weed out the maybe upcoming research that hasn't necessarily been validated from the final recommendations, those kinds of things? Feel free to jump in. Vicki, Anna, we haven't heard from you. Go ahead, Vicki.
Yeah, Anna, you can go ahead.
No, go ahead.
Okay, great. What I'll share briefly too is just in regards to research, because oftentimes we hear the term research, but what does that really mean? So the biggest thing is looking at credible sources. So for instance, the NIH or the National Cancer Institute, that they have a public access platform where folks can go on to look to see what our current research innovation happening, current treatments, drug therapy. So that's one source. And then there's also different organizations such as the Breast Cancer Research Foundation, American Cancer Society. These are all organizations, especially around this time, that is publishing new and up-to-date information in regards to what's happening with cancer, any innovative treatments, immunotherapies, and so forth that are happening. So I think those are the best public access resources. And then also speaking to your provider as well too. Oftentimes we think we have to go and down the rabbit hole ourselves, but really your providers are constantly doing training to keep up to date in the field as well. So communicating with your OBGYN and asking them what information that they're aware of as well.
That makes sense. Great. Thank you,
Thanks.
Anna.
I was going to especially echo the talking to your provider, because you have, all of these potential risk factors that you hear about, and you don't know how important each of them is in determining your overall risk if you're just the average person, but your doctor can help you figure that out. And so it's important to stay in communication with your doctor and talk with them about any changes that you see, and talk about anything that comes up that might be a new risk factor, because they're the ones who know you the best, at least your medical history the best, and can give you their expert advice. Since I am a breast cancer survivor, I have a slightly different tack than all the folks on this call. I found my tumor myself. And so I know that the breast cancer screening recommendations don't encourage breast self-exams. But if you think that that would be a helpful tool for you, especially if you're under the age of 40 where you can't get mammograms yet, that's something you could discuss with your doctor and see how relevant that is for you, to see if that might be something that would be worth doing. And then, of course, get your doctor to instruct you how to do it, so that if you do it, you are doing it correctly.
Mm-hmm. Yeah. On that, Anna, I think as we're saying, these recommendations have changed or continue to change. Other than talking to our doctors, is there anything else we should know about these changing recommendations for self-breast exams?
Do any of the clinicians want to talk about that from their perspective, and then I'll chime in?
I'm happy to, or Andrea, if you'd like to, feel free.
Oh, Andrea, and you're on mute. There,
Oh,
now
you're still muted.
One more.
There we go. Sorry. The problem for some women, I should say, not all women, with routine self-breast exams is that it increases anxiety, it increases medical care, testing that would not have been performed, and overall it may increase anxiety through all those measures, which is why they're leaning more towards the self-awareness, which is very similar but slightly different.
And I'll add that I tell every woman that to be aware of their body. So, and I tell every person really to be aware of their body. And if there's anything that's concerning to you, anything that's changing, anything that doesn't feel right, to bring it to, your healthcare provider, that there's no bad question to ask. If you're concerned about something, it's okay to ask about it and to get feedback. It could be nothing or it could be something. And so for some people, it gives a lot of comfort to do breast self-exams, and it gives a lot of reassurance and a little bit of control. And so that's wonderful to do. Then you should. If for some people it does cause anxiety, worry, fear, then don't. But at a baseline, really understand your body. And if it's changing in a way that you don't understand, that you would like to discuss, bring that to somebody. I think that's sort of the baseline goal for breast self-awareness, is just to know your body. And some people want to know it a little more by doing exams, whereas other people, that doesn't serve them well, so they don't do it. But that baseline still exists.
Yeah, that makes sense. I'm curious, so whether, you know, you've done a self-exam and there's something that you have a question about, or you go in for your regular screening, I'm curious to get the perspective around how has screening changed recently? Like what do you expect? What should you expect when you go in for screening?
I'm happy to get started with that.
Sure.
So, you know, and I know we're focused on breast cancer, so I'll really try to keep there. But screening in general for cancer is just rapidly evolving, which is a good thing. And there are consequences to all good things. So there's, you know, the over searching, over finding, over diagnosing that Andrea talked about is a real thing. But the benefits outweigh the risk for routine breast screening, because we know that it's effective, can catch cancer at an early treatable stage, and has been directly related to the improved mortality rates associated with cancer. So what's changed, I think, in the most recent-ish history is focusing on understanding your breast density as a risk factor, and then reporting that back to people and providers through breast imaging, and then also the addition of routine breast ultrasounds along with mammograms. So everybody's body is different, and everybody has lumpy, bumpy bodies and breasts and changes in their tissue. And most of those lumpy, bumpy things are not cancer. However, oftentimes, particularly early on in screening for a person, it's difficult to interpret because there's no prior images for the radiologist to compare to. And so a second look is pretty common. And so adding in the ultrasound has helped reduce maybe some of those additional maybe biopsies or tests that could cause harm. And an ultrasound is pretty benign, pretty accessible, and just helps clarify what those findings are. So I think young premenopausal people often have findings on imaging. And so now we're finding new ways to address that, to reduce impact, but improve, you know, outcomes.
Sure, that makes sense. So just a reminder, if you have any questions, feel free to go to the Q&A and enter them in. I have one more question I'd planned to ask, but I saw a question come in that really relates to what we're talking about here. So I'll ask that first and then go back to my other question before we get into additional questions from the audience. But the question that has come in is, can you speak to dense breast tissue? What does it mean, and how does having dense breast tissue impact patients?
That was going to be my last comment when I was talking.
Perfect.
So when you see dense breast on your mammogram report, breasts are made of fibrous, dense tissue and fat. So dense breasts have more fibrous tissue than fat. And though the breast density is normal and common to see on a mammogram, the density can impair the radiologist's ability to interpret the report and may miss something suspicious for a cancer. So when you do see that on your report, you need to discuss with your provider that knows you and your breast best what would be the best thing for you, and make that shared decision making, go through that shared decision making process to make a decision on what, if any, further testing should be done.
Got it. Is that where, Megan, the ultrasound piece, I didn't know about that. Is that where the ultrasound may come in?
Yeah, I think what the ultrasound does is just helps look at the breast tissue in a different way, because it's hard in a mammogram. Many women are, you know, breasts are dense when you're premenopausal. It's not uncommon. And so it can be difficult to, the images can be challenging to interpret. And so the ultrasound just is a different way to evaluate the breast tissue. And more routinely now we're seeing our radiology colleagues recommending ultrasound in addition to mammogram, just to be able to stop the need to come back multiple times for multiple visits or maybe have unnecessary testing.
Dare I ask, is this something insurance is keeping ahead of, and are we seeing coverage for those things?
What I
Hold you
found,
to it, but
what I found was that the screening mammogram is covered. But then if there's an ultrasound or follow-up mammogram, then that's considered diagnostic and that goes towards deductible.
got it. Okay.
So that's part of the conversation I always had with my patients,
Yeah.
what to do about this. And we really need to discuss and talk about what it really shows and what it really means to you as a person.
Sure.
And I think one additional thing I'd add to that is the ordering provider could potentially just order the mammogram and ultrasound combined as a screening.
Mm,
And I can't speak to every payer because there are way too many out there to be able to know all the different
Sure.
coverage, but that's one way if they're coupled together as a screening order to think about success with coverage.
interesting. Interesting. And that's something to, of course, discuss with your provider as well, is
Yes.
how can we go about this and partner. On that, because someone else asked a question related directly to this, so we'll roll with it. Do ultrasounds remove the need for an MRI for screening?
No,
So always have to do that
Absolutely
MRI.
not.
Okay.
you don't always have to do an MRI. So a person at average risk for breast cancer is not routinely recommended to undergo a breast MRI.
Okay.
For people at the highest level of risk, so those who have a greater than 20% lifetime risk of getting breast cancer, average risk is about 13% lifetime risk. So when the risk goes up to about 20 to 24%, then that's the threshold in which adding in additional imaging is recommended and more frequent imaging is recommended. And so
Got it.
that's based on family history as well as personal history and personal characteristics.
Got it.
MRI is not a routine breast imaging for the average risk individual.
Okay, so kind of at the stages, it's the first screening, which I don't know the technical name for, what we go in for every regular
Your annual wellness screening. Your
annual
mammogram.
wellness screening, then potentially the ultrasound and or the MRI, depending on risk.
Yes, so if
Okay.
so the MRI is really limited to those who have a greater than 20% lifetime chance of getting breast cancer. I think that's based on evidence. That's also based on cost. You know, it won't be considered a reimbursable recommendation if there's
Sure.
not a certain level of risk threshold made. And there's risks and benefits to all screening. And so adding in more screening isn't always necessarily a good thing. And so for the average risk person, that wouldn't be part of their routine plan.
Got it. Okay. Okay, really interesting. So I'll get to my final question that I had planned to ask, and then we've got more coming in that are really great. So let's make sure we get to those as well. Thanks everyone for submitting those questions. So I tend to be a very action-oriented person. I think women in general, we want to fix things. We want to like solve the problem. So we've been talking a lot about screening and just understanding our risk. What can we do to decrease our risk of breast cancer?
Shall I go first? I'm
Sure,
going to be short. Okay. So I already went through other risks. And basically, the two biggest risk factors, which are being genetically a woman and two, advancing age, you cannot change. The other things is to maintain a healthy body weight throughout your life, which the BMI for that is 18.5 to 24.9. I can't tell you a handful of women basically in my practice ever were in that weight range, because a lot of women in the United States are now higher than that. So I wonder if that's going to change. Exercise, 150 minutes moderate, 75 minutes intense weekly. Limit or avoid alcohol, and breastfeeding your babies may decrease your risk.
I'll add one additional thing because there's emerging data about independent of physical activity, just moving more and sitting less. So not being sedentary, which is hard when we're all in a webinar. We've been sitting for an hour, but
Mhm.
not everybody can achieve physical activity for a variety of reasons that are both related to their own bodies or maybe even their environment in which they reside and or where they are in the world. And so not everybody can do physical activity, and that's okay. Obviously, that's always the goal because it's good for our brains, our hearts, our bones, our, everything, not just our cancer risk, but so is moving more and sitting less. So getting up and walking to the mailbox, not having prolonged sitting time, really trying to increase the amount of time that we are moving can be protective as well. And there's more and more information coming out to show that that's independent of physical activity. So yes, physical activity is the goal. Sometimes it's not a goal that some people can achieve for a variety of reasons. And if you can't reach that goal, it's okay. Think about the goals you can reach, and even just moving more is a good thing.
That's great.
And
Well,
I'd like to add a little
Yeah.
something
Go
here.
ahead, yeah.
Yeah, so as Ashley mentioned in my bio, one of the things that I have been interested in is making sure that people have access to information about risk of breast cancer. And when I was diagnosed, I had 2 other friends that were diagnosed within 5 months of me. And so I was really confused by that and really questioning what is going on here. And so when I talked to my doctor, she was explaining to me that there's actually some higher risk of breast cancer if you have your first child after the age of 35. And I had always heard that you might be at higher risk if you never have children, but I had never heard that you could be at higher risk if you have children later in life. And so this was quite a surprise to me, given that I work in public health and I'm very prevention focused. And so I asked her why we don't hear about that so much. And she said, well, they don't want people to panic. And I said, well, I think in general, most of us are smart enough to know that just because you have a child after 35 does not mean you're going to get breast cancer. And if we know that there's the risk there, we can do something about it. If we don't know it's there, then we're not paying any attention. So I wouldn't have changed when I had my children, which were after the age of 35, but I would have liked to know that that risk was there so that I could be aware, especially because the screening recommendation with mammograms starts at age 40. And my diagnosis was when I was age 38. So the only way that I found it was by knowing my own body and questioning when I found a lump. So I just want to also, spread that awareness, because I know that especially a lot of smart women like University of Rochester graduates might have a tendency to go on to graduate school and, start their careers before settling down and starting a family. And so I just want people to be aware that that risk is there and to just really pay attention to your body and to know that it's something to look for. It's something to think about. Not that, you should panic, but that you should just be aware.
Yeah, I appreciate that. And Anna, there's a question coming in specifically for you, I think related to your experience. We've got some great questions here. I'm going to ask 2 more, and then we'll turn it over to Anna, who's going to talk a little bit more about breast exams, and we'll get into that before the end of the program. But Anna, the question was, when you were diagnosed with breast cancer, what do you think is important to ask your providers and village of supporters in the first few weeks and months? I mean, it sounds like some of your village were going through exactly what you were going through. So interested to get your thoughts there.
Yeah, and I'll say that what I noticed was a lump when I was breastfeeding my second daughter. And I thought initially that it was like a clogged milk duct or something that would just resolve itself. And it didn't. After about a month, it was still there. And so that's when I said, I have these 2 friends that were just recently diagnosed. I should at least go check it out. if it's nothing, it's nothing. But if it's something, then, early detection is the best outcome. So I went into my doctor, and she, because my breasts are dense, she actually ordered an ultrasound first, and had that checked out, and then referred me to a mammogram and then to a biopsy. And so all along this time, I really thought that it was nothing. And so I was quite surprised when I got my diagnosis, because there is no family history. But I, really took it in stride, because if you panic, there's nothing that benefits you. And if it is nothing, then you've worked yourself up over something that isn't a worry. So I would just recommend, going through the process calmly, which, believe me, I know is hard, better, easier said than done. But and really taking each step at a time, and asking questions, and making sure that you get the information that will help you make decisions. And so I just kind of went through each step. And when I got to the point where I received the diagnosis, I said, what can I do now? And so I really focused on, going through the treatment protocol, and letting my friends and family know. I actually signed up for a website that lets you put out there on a calendar needs that you have, and your friends and family can sign up. And I have to say, that was one of the really, really helpful things, is that no matter how small, people like to help. People like to let you know that they're there for you. And so even letting somebody, pick up your prescription or go to the grocery store for you is really, helpful for them and helpful for you. So that was one of the things that I found really supportive during my treatment.
That's very cool, that kind of calendar thing.
Would it be okay if I add one small thing?
Yeah,
I
please.
think there's two things also that tend to really help, is bringing somebody along with you for those initial visits, so that you can have another set of ears to listen during a very hard time, when maybe the things that you're hearing aren't sticking, or you just are learning so much information that it's impossible for any one person to really know it all. And so having somebody come with you is a really powerful and beneficial thing. And I also think, just to say, trying not to panic is always a good idea, but I don't know if anybody in the world lives with anxiety and knows, you can tell your body all you want not to panic, but if you're going to, if it's going to happen, it's going to happen. And it's okay to tell your healthcare team that you need help, that you maybe need to talk to a social worker because you need practical help. You might need a counselor to just walk through even the shared decision-making process and weigh all these options, that maybe you need to take a breath and take a break for a minute and go have some food, and or know if in your community there are YMCA programs or things where you can have a community of support. Because even though the ideal for everything in life, right, is that we just do it great, oftentimes when we're a time when somebody is diagnosed with cancer isn't the best moment in their life, where they're at their highest and best. And so it's okay to say that you're not okay, and to ask for help, and to let people know.
Yeah, those are really great points, Megan. I would have also said bring somebody with you to help take notes, because it's a lot of information. And definitely, support is needed, whether it comes from your friends and family, or whether it comes from a support group, or wherever you get the help. I personally am in a support group still, even though I'm 12 years out from my diagnosis, because these are people who have been through a very similar experience to me, and they know how it is, and they know how it continues to impact your life even years along. So that social support and support of other people who really understand is so important.
Yeah. Wow. Well, first of all, thank you all for this information. I'm so glad we have it recorded, because I definitely want to listen back, and hopefully others will as well. We have just a few minutes left, so I want to make sure, Anna, that we can talk specifically about knowing our own bodies, talking about how breasts change during our cycle, how they change through, you've kind of touched on a little bit of reproduction, menopause, just a little bit, but can you talk a little bit more about that as kind of our last topic here?
Yeah, I alluded to it before, but I just, want people to be as aware as they can. The recommendation is not to do detailed breast self-exams, regularly, but that doesn't mean that you can't sort of check out how your breasts normally feel. And, if they're very dense, know that sort of which lumps and bumps are normal and which are there all the time. Because then if you feel something new sometime, or you look in the mirror and you see something, pucker or dimple or something, then you know that that's different.
Oh, Anna just went on mute somehow.
Oops,
There we go. You're perfect.
bump the space bar. Sorry.
No worries.
What was the last thing you heard? Sorry.
You were saying if something was puckered or dimpled,
Oh,
and the next
then
line
you know
was
that it looks, yes, then you know that it looks different than what it usually looks like.
Mhm.
And as I noted, because I was diagnosed at age 38 before routine mammograms, it was really important when I noticed something to pay attention to it. And like I said, I didn't panic about it because I know that there are lots of, changes that can happen, especially with breastfeeding. But I wanted to keep an eye on it. And so when I noticed that it didn't go away is when I decided that it would be the smart thing to do to check in with my doctor and just make sure. And so I think that, they don't want people to over test, to go running to the doctor with every little tiny thing that they see. But you do have to know when is the appropriate time to go to the doctor. And so, as somebody mentioned earlier, there's lots of lumps and bumps that are not cancer. And so it's important just to realize that just when you feel something doesn't mean that, oh my gosh, you have cancer, but it means that you should just, pay attention to it, keep an eye on it. And if it seems to not go away or it gets bigger, then make sure you go in and just get it checked for your own peace of mind, but also, just in case, especially when you're not able to get mammograms, that's your only preventive weapon.
Sure.
Just one addition to that. When someone notices a lump, they tend to feel it all the time. When you feel it all the time, you increase the swelling around it. So try to do maybe weekly exams or every 3 days, not, constantly feeling throughout the day, because that's what we all do. And it's hard not to.
Sure. Yeah, that's a great point.
That's good advice.
So Anna, it sounds like if I could kind of summarize, understand your baseline, whether it's, with your first screening with your doctor or, just through, your own personal experience. And then from there, if you see something change, don't panic, don't touch it all the time, right? See how whether it seems to be continuing to change, if it's still there, and seek guidance when when appropriate from that point. But know from the kind of the baseline is what I'm hearing. Understand that first. Great.
Because you're in your body every day, and so
Right.
you are the one who knows if something's different. And so it's important that you be the one paying attention and, not assuming the worst, but just being aware and being able to advocate for yourself if something seems amiss.
Sure. Yeah. Well, amazing. As I knew we would be, we're coming right up against the hour. It's 9:02 my time, so we're just 2 minutes over. I'll count that as a win because there's so much great content that we went through here. I want to thank Anna, Vicki, Andrea, and Megan for all of the great tips, advice, insights. We appreciate you. We appreciate you supporting our community of women through the University of Rochester Network. And I know Sarah will be sending out, Vicki mentioned NIH. There were some resources mentioned. I know I was chatting with Sarah on the side. She said she'll send those out as a follow-up so that we can all have those resources as well, in addition to the recording. But really, really appreciate the time today. Appreciate everyone in the audience for joining us. Hopefully, you've received some new tidbits of information that can help you feel more comfortable, feel more familiar with just this topic, and take action when needed.